We have a panel of 4 folks today. I want to thank each of them for joining us.
The factors that would make us believe that we need to admit an adolescent to the hospital is, number 1, imminent risk for self-injury and not having the ability to develop a safety plan. So that child or adolescent is just not able to adhere to a safety plan, so therefore they're possibly injurious to themselves. Also, an imminent risk for injury to another person would be another criteria. Acute or serious deterioration from their baseline ability. In other words, they deteriorate from their ability to cope and manage on a day-to-day basis. And that would include management of their activities of daily living, bathing, eating, things like that. So that would be the other criteria. The other one might be that the patient is just not stable enough and would benefit from a safe environment, a good milieu in order to begin to work on their personal goals. Now that's a little, that they have to be pretty sick to get to that point, but that's one other issue. The other one would be whether they have a medical condition that is associated with a psychiatric illness, so that the medical condition is deteriorating. Probably they would be admitted to a medical facility first, and then after that to a psychiatric facility. And then for those that have eating disorders, if a reduction or a loss of 15% below the body mass index, so they're lost quite a bit of weight. The things that would exclude a young person from going in would possibly be a primary medical condition that if the medical condition is primary, and then they would be admitted probably to an inpatient medical facility, and then the other would be for primary substance abuse issues. So.
How many of you right now use your primary care provider for mental health needs? We know that most people who present, particularly with anxiety and depression, present first and may present only to their primary care providers. And we are actively engaged, and the evidence in the literature would suggest we would do well to engage with primary care providers to help them screen and assess both youth and adults and try and provide the highest level of care they can in that setting with support from those with greater expertise, to the point that specialty care is really needed. We're aware that a lot of folks who present in primary care don't want to go to specialty care, don't like the idea of going to see a counselor or a therapist or a psychiatrist, and beginning their care in the primary care setting is a way to begin to introduce the idea that treatment is available, treatment can be helpful, and that if initial attempts at treatment are not successful, then perhaps reduce the barriers to them being referred to a higher level of care. So we're actively engaged in Washtenaw County and at the University of Michigan in trying to implement a particular kind of evidence-based collaborative care with our primary care colleagues, where we place someone, usually a social worker, sometimes a nurse with behavioral health or psychiatric expertise, in the primary care clinic to do screening, and then bring in a psychiatrist consultant to work with the primary care professionals to begin treatment, to follow periodically in terms of symptom measures, how people are doing, and if folks don't respond well, then to step them up to higher levels of care. And in my mind, part of that is trying to improve the continuum of care that starts in primary care and moves then to specialty care clinics, so that folks can get their needs met at the appropriate level as early as possible, because we all know that early intervention is key. So there's a lot more to say about that, but I'll just give that as a background and then turn the mic over to a colleague.
Certainly when it comes to children and adolescents, which is my primary area of specialty along with young adults, is that if a parent notices something that is not typical from that child's behavior, we probably always want to start out with their primary care provider, pediatrician, to look at anything that deviates from that child's baseline functioning before we, escalate the level of care, because developmentally, that pediatric provider can probably give a really, can start that assessment before we start to seek out care from a psychiatric professional. However, I think we're going to see embedded in care much more of the integration between primary care and psychiatric mental health care. We're already seeing that now. So I think having social workers embedded in pediatricians' offices and also having pediatric or family psychiatric nurse practitioners embedded into primary care offices, so that if we do notice that someone's coming into the office and really they could be served best by mental health care, that there's a warm handoff there and a familiar face and someone that's in the office that you are really able to feel comfortable with, because your primary care provider is able to introduce you to that professional, versus having you have to wait a month to 2 months to get into care. So I do think that we'll be seeing much more of that, and we should expect that integration in our care. It will provide the best quality of care for all of us.
My question, I believe, had two parts. The first one is, what is pharmacogenetics? And briefly, pharmacogenetics is how differences in individuals' genetics can impact how they respond to drugs, and that can be how well they respond or their chance to get side effects. And then the second part of the question is, how can pharmacogenetics play a role in patient care? I think is best answered with an example. A lot of the tests available today assess how well your enzymes function that metabolize drugs in your body. So if you complete a genetic test and you find out, I'm a poor metabolizer for X, Y, or Z gene, it's important to know, because drugs metabolized by that gene can be started at a lower dose or used not at all.
We know that lithium can be extraordinarily useful for folks, and that the risk of effects on the kidney increases over time. But I would not endorse a hard and fast rule with that. Part of what we do in managing lithium with individuals who do well on it is to periodically monitor their kidney function, their thyroid function, to see if there are issues coming up. Obviously, we respond to problems that come up. I will say that it becomes a little bit more challenging as we all get older, and kidney function just by age begins to change and sometimes be reduced to continue to manage lithium. But the use of it doesn't need to stop unless there's some significant problem that makes its use risky for the individual. So a hard and fast rule I would not endorse, but careful monitoring would be the way to go. So I think the literature there, and it's been a while since I reviewed it, doesn't give a clear signal on that. And you'll find, both in terms of managing renal effects and just side effects in general, varying opinions about whether to divide or take it all at once. A little bit, I go with what's easier for the individual taking it to manage, and sometimes once-a-day dosing is easier to remember. And so if it's a choice between taking the full dose or forgetting it with a split dose, we'll have that sort of a discussion. But I don't know that, again, there's a clear signal one way or the other about which way to go. Sometimes you can try it one way and evaluate both response and side effects, ability to take the full dose on a regular basis, and monitoring kidney function tests. But again, that's part of the, I guess, the clinical care management and the partnership with the person taking it to try and figure out what works best for them. Do you all know what transcranial magnetic stimulation is? It's a form of treatment which applies magnetic fields to the brain in a conscious individual who doesn't need sedation, doesn't cause a seizure, but it is believed to alter circuit function in the brain in a way that can be helpful, particularly for depression. It's also being studied in a number of other conditions. You're going to hear later one of my colleagues, Dr. Cynthia Burton, speak about, well, I think, I shouldn't put her on the spot, but talk potentially about the use of transcranial magnetic stimulation or other forms of electrical stimulation to the brain below the level of what ECT delivers to the brain, to look at cognitive enhancement in those with schizophrenia. So obviously it's a tool that we have that is safe, relatively well tolerated, with exceptions. Sometimes folks can get headaches and that sort of thing. But I think the evidence needs to be built for use in unique settings. There's some evidence to use TMS to treat hallucinatory experiences in those who have psychosis in the form of hallucinations. But on the substance abuse side, I'm not aware enough of what that literature is, or that we use it exactly in our clinics. I may be wrong. But if so, it would be under a research protocol to try and understand what the benefits could be in a carefully sort of designed and controlled study. I will say that we do think a lot about the psychiatric illnesses that we treat as we're trying to understand them to a greater extent in terms of brain circuitry functioning in ways that are problematic. And the use of treatments like medications, like psychotherapy, like TMS are all designed in a way to try and help rework some of those circuits in a way that allows people to function with less impairment and at their highest level.
But there are test kits available, and if you can get it before you start treatment, it can help guide you. It's a difficult issue with a lot of questions that need to be answered in terms of how cost effective is it to test before or after, but I think it's an exciting area of research.
There are always studies going on to try and develop new treatments. I'm not aware, honestly, of where the pipeline is in terms of new medications for schizophrenia per se. There are medications coming out, which I guess I would say in general represent some attempt to advance in terms of side effects and overall management, but we're all kind of waiting for a game changer in some way to come out, and I don't think I know of anything that's on the horizon. The issue of a medication to improve insight is a really good one, and I'm also not aware of any medications that do that exactly. The approaches to work on impairments in insight for those that are affected are really more psychotherapy based, to try and figure out ways, often using cognitive behavioral therapy or other approaches, to engage the individual, whether or not full insight ever is achieved, to be a more active participant in his or her treatment in a way that ends up helping them and being constructive.
I don't know the name of it, but there's a newer med out there. The long-term injectables are really helpful because then you know that the patient is getting the medication on a regular basis. And at least in my experience, and I'm sure for those that are out there, that in general, insight can improve when a person is properly medicated, because they are more stabilized, and then such psychotherapies, etc., are better, are better. Basically, they can respond to those better. So I think the thing I'd like to say, and what NAMI often helps families with, is how to, through their educational programs, is how to help a person understand, so how to deal with persons with a mental illness, so that you communicate better with an individual with a mental illness. So we always, through NAMI, which I'm very involved with, encourage families to have the book, I Am Not Sick, I Don't Need Help, which really helps you to figure out how to talk with somebody. So I think the point is that there's therapies that are psychosocial therapies that are very helpful in that manner. So thank you.
Margaret? Thank you. This is kind of an offshoot from that question, but just kind of going along the lines of what NAMI has to offer in terms of support with the Families in Action program can be very helpful in connecting you with other families that might be experiencing similar challenges, either within your family or a loved one. So if you're not familiar with that program, I would highly recommend talking with your NAMI in whatever county that you're in, because I think that can be very helpful. And the reason that I thought of this was because as you're asking about new medications or medications on the horizon, sometimes we know what we know from reading it, but I think all of us kind of like to see how things work clinically as well. With some of even the newer antipsychotic medications that have come out, It's not always feasible to use them because of insurance, and so we have to be mindful of that too. Because I read the literature, but also anecdotally, I'd like to have enough patients where I can say, okay, what I read, I'm really seeing with my patients and feel confident with that as well. Also, if I know that it's going to be a problem in terms of insurance paying for a medication, I certainly don't want to start someone on a medication where I know that they won't be able to access it or with any sort of ease. So some of the research that I've done has been with a school in Southwest Detroit. That's where I've done some of my mindfulness research with youth and adolescents that are particularly at risk because of adverse childhood events. So I do know that in Detroit they screen using the RAPS tool, which is terrific. And a lot of schools throughout Detroit have clinics embedded in them, and I know Henry Ford Health System has a big investment in that. And all of the children who have consents to be able to be seen in the clinic have a RAPS assessment completed on them, which is a psychosocial assessment that looks at a variety of aspects of the child's life. So through that, that was actually helpful for me when I was doing my research because we were able to gauge who was at most risk. I do think that when it comes to pediatricians or primary care, we should be asking the question about, who do you refer to for mental health, and do you have that toolkit? I know when I'm teaching my students, I make sure that they all have a toolkit of providers that not only they know the name and number to, but that they've actually reached out to and met, so that they can confidently say, I feel comfortable sending you to this person. So I would want my own pediatrician for my child to have a toolkit if he or she wasn't able to or didn't feel comfortable addressing my child's needs, to be able to have colleagues that they know and that they can help me access.
I think from a pharmacy perspective and trying to understand how well a drug is working for a patient or if it's causing side effects, the simplest response is it's difficult to tell what the marijuana is doing versus what the medication or the therapy is doing. I know when patients come into clinic and they are using marijuana, it's often encouraged to decrease use as much as possible. I don't know anyone prescribing it, like medical marijuana for severe anxiety, but I am going to pass this along to the more experienced clinicians to chime in.
So in the state of Michigan, nurse practitioners are unable to write out the certification for the use of marijuana. But I will say in clinical practice, we really do discourage the use because, of course, there are also the issue of other medications that the patient may be on, such as benzodiazepines, if that is something that's offered. And if a person is already using medical marijuana, and often we don't know to what degree they are using it, even though we ask detailed questions about that. It's just it makes the issue clouded because they are receiving medications and we don't know the result or the benefit of the medication. I don't know. That's all I'm saying. I pretty much restrict the use of benzodiazepines for sure in those situations.
So I would say at the University of Michigan, we're not prescribing it and not encouraging it. I will tell you how clinically I try and manage it. So it's not uncommon for folks to come to me saying they're using marijuana either prescribed by someone else or unprescribed for the conditions that they're seeing me for, and that they're very wedded to it. And so we begin a conversation gently over time, which starts from the premise, if it was working that well, why are you seeing me, right, in some way? And also to try and figure out what are the variables we have to apply in treatment and how can we see if those are working. And if they're not working, eventually have to get to the marijuana as one of the variables we have to address. So sometimes folks are reluctant to do that right up front, and I get that. So we'll talk about other treatment interventions, but if those don't work, then we need to go and look at the variable that they were unwilling to look at from the beginning. So that's part of the partnership over time to work towards that. Sometimes it works, sometimes it doesn't, but it's important to ask the question, what would things be like? How would you feel if you were using less or none of that? And while we work on the other parts of your treatment. You know, it's a question of how to engage someone in treatment and how the alliance goes, and trying to identify how much they're suffering from symptoms and how much it's impairing them and what's going on and what are the variables we can address. And so I try and be systematic about that. You know, if you're only taking marijuana and yet very symptomatic, what does that mean? You know, is that an effective treatment, and what else could we do? And then at some point try and figure out what role it plays, if any, or how things would look off of it. So I'm compressing what may go on for months or a year into a very short statement, but that's, at least for me, the kind of approach that I'm trying to take with folks.
There is no medication specifically indicated for borderline personality disorder. However, we would look at the symptoms that are most problematic for that individual and treat them with medication. The second part is that for an individual living with borderline personality disorder, we would probably recommend a combination of both medication to treat those really problematic potential mood symptoms that they're experiencing, as well as therapy, so in combination.
I would agree with that. I think the most effective treatment for someone who has a lot of mood or anxiety or other symptoms as part of a borderline personality challenge is a combination of medication and therapy. Medications alone are unlikely to deal with all of the issues, and part of what DBT is effective at doing is helping, one, interact with one's environment in a different way, which I think is part of the treatment over time. The other question was, does borderline personality disorder change with age? It can. There are some studies which over time show that some of the intensity of the symptoms can decrease over time. It's not clear, obviously we'd like that to happen with treatment. Whether it happens on its own is a little bit harder to see, but there have been some longitudinal studies that show that over time folks tend to be able, maybe because of life experiences and learning from those, to dampen down a little bit some of the emotional intensity that can be much more prominent in younger days. The Genes for Good program is a research study which is looking to collect genetic samples from as large a population as possible to begin to look at the complex interaction of genes and environment across a whole number of disorders, not just psychiatric disorders, but medical disorders. And if you've looked at any of the work about precision health or precision medicine, you understand that with complicated illnesses that we all are talking about and dealing with, there's not a single cause, genetic or environmental or otherwise, but a complicated sort of constellation of genetic changes and environmental. And so in order to understand that in a rigorous way, very large populations of folks with a variety of conditions are needed to contribute their genes. And so the Genes for Good project is looking to amass as large a population as possible so that with sophisticated data analytics beyond my expertise could be used to try and understand where genes and environment interact to manifest, not just for the kind of illnesses we're talking about here, but diabetes, high blood pressure, cardiac disease, cancer, etc.
I think that part of the reason pharmacogenomics developed is because they noticed these lack of patterns in drug response. But with that being said, I don't think it's perfect right now, and there needs to be a lot more research done because it's likely that one or two variants isn't explaining all the variability in drug response. So we're going to have to keep on doing research to really understand what's going on. But I think it is promising.
Dr. Ward and I were talking just before we came in here about trying to get a protocol up about trying to get testing more regularly. Trying to get that testing done through the primary care setting is possible, but it's not used as a routine test. It's sent out to a special lab. And so it's possible to try and facilitate that, but it would take a little bit of effort. Maybe we can talk about that afterwards. In terms of the West Ann Arbor site, so that clinic will be opening, I think, in November. And it will have primary care there. At this point in time, we are going to have some effort from geriatric psychiatrists trying to have a clinic there for older folks. And we're also trying to bring in the integrated care program that I spoke about earlier with a behavioral health trained social worker in the clinic connected with a psychiatrist. So it might be possible then to provide more support for the primary care doc to feel comfortable with what he or she is doing right now, and to create a relationship that might allow us to, if the needs can't be met there, to try and get someone like your son to the right level of care. So we're working on that at this point. My hope is that by the end of the year we'll have something in place, but that's an active effort right now. I'm always pained to hear issues where, access is hard enough to get when you have insurance. It's harder when the insurance becomes a barrier. So I don't know exactly what to say, and that requires someone with expertise in the insurance business. But the fact that you're willing to pay hopefully should reduce the barrier to get someone to see your son. So, but we struggle. We're struggling day by day with what insurance will and won't cover. Many of you know that mental health benefits are poor, carved out, or not available in a lot of places. And so the struggle to try and address that goes on. I don't know how to be more helpful directly in your care, but I'll see if colleagues have suggestions.
I would say two things. One would be, as far as the insurance piece goes, call the company and find out who, if anyone, they handle in Michigan, or how that reimbursement would work for you, so that you know ongoing, once you have a provider, and you might have already done this, to find out how that will happen for you, so that you don't always have to continue to write a check, because that could certainly be problematic in the long term as well. And then I would, I'm not sure, where you live, where the locale is, but I would reach out to individuals here and find out, get some recommendations, and potentially, unfortunately, start the process again of calling and making an appointment.
There's good evidence that the combination of medication and a variety of approaches can help improve the level of function of someone who is suffering from schizophrenia. Some of that is approaches that I would put under the broad category of psychosocial rehabilitation. Some of that I would put under the rubric of CBT that I talked about earlier, which is helping folks cope with persistent symptoms that are not fully treated by medication. Some of it is helping the family and the patient together. I don't know specifically what the situation is for the person who questioned, but a variety of those approaches have shown benefit and can be helpful. Obviously, it's an ongoing process dealing with the challenges that everyone faces in life that vary from individual and family to family in terms of trying to optimize the care. But it's always, I think the best outcomes come from the combination of meds plus those kind of interventions.
And I would also like to add on that what we do know, the research shows that when there is reduced emotional expression in the family, that helps, that reduces rehospitalizations over time. And so programs, I'd like to echo what Dr. Dallek just said, is that programs that are helpful to the family will help with communication patterns, help to reduce emotional expression, because that can become a trigger. But what also, the programs that NAMI has, the family-to-family program, that is an evidence-based practice, and has shown that families and individuals who are coping with mental illness actually are much calmer, they feel much better about what to anticipate. So it's important to continue to work with the professionals for cognitive behavioral therapy, and then families to and individuals with mental illness to get their own treatment or psychoeducation. And then there is family psychoeducation, which is another evidence-based practice that's offered in the community mental health centers that include both family members and the individual with mental illness together, so they can sort through mental illness information, diagnosis, treatment, and communication, empathy, etc. So.
Number one, it depends greatly on whether this is her first episode or whether it's multiple episodes. If it's multiple episodes, the chance of relapse goes up much more. But for a first episode, I think an attempt at discontinuing medication is worthwhile. I think a year is a reasonable time, and you do it slowly for two reasons. Number one, the slower you go, the less likely there is to be an abrupt relapse. And number two, the slower you go, the more likely you are to catch a relapse that's beginning early so that you can nip it in the bud. For lithium at least, and my own seat of the pants belief is that this is true for medications in general, is that once you let a person relapse, the same medication that helped before becomes somewhat less likely to help again. So there's a long list of reasons why you don't want to relapse. You don't want the relapse because it obviously is a sickness. You don't want to relapse because it may make the medication that worked no longer work. And I think those are the rules. And if someone's had three distinct episodes, I think you have to be very careful about when you stop the medication, if ever, depending on what it is.
The only other thing I would add, and Dr. Cameron was a senior expert in our department for many years, I would also integrate the family history. So for someone who has a family history which is highly prevalent for depression, there's a little bit more of a discussion about, for a young individual, the risk is probably higher that there are relapses. If it's the first person in the family who's had that, then I would agree with the year and if it's only the first episode. But if the family risk seems higher, then a little bit more have a discussion about that. So the same approach if you're going to taper off the meds.
And the other thing that I want to point out is, I'm glad to hear your daughter's doing so well. With her being 20, you also, if things are going great and it's, it's around graduation time and life is really good, and she starts to think things are great, it's time to taper now, and has that discussion, it's really important to pay attention. That's a big time of transition. And so we need to pay attention to those life transitions and developmental phases when we start to consider, is this really, even though things are going great, the best time to start the taper?
There are people who have an episode and never have another one in their life. But you can't assume that that's going to happen. You've got to be very vigilant.
When you initially see a child particularly present like this, you want to rule out anything medically that can be going on. So it seems like they used, their best judgment in terms of doing that. But now it's really the time to address those issues of anxiety with a mental health professional. Because I think a lot of young people in particular, unfortunately, depression and anxiety is highly treatable, but not, as many people as we would like get into treatment, or it's difficult to access treatment. But now is really the time to have an assessment done by a mental health professional to really figure out what is that anxiety and anger all about. And if this is time to, it's certainly time to probably initiate something, whether that's therapy and medication, and what the order of that would be is important. So I would say the next step is a psychiatric assessment.
I want to thank our panel I want to thank all of you for attending and asking questions. I want to thank NAMI for putting this on.